And I will introduce our first speaker. She was kind enough to join us. Her name is Dr. Gudrun Schleiermacher. Oh, sorry if I killed that. Is a pediatric oncologist and researcher and works as a physician scientist at the Institut Thierry in Paris, France, where she is the delegate director for translational research of the CIRIDO Integrated Pediatric Oncology Center and a group leader of the INSERM labeled Translational Research in Pediatric Oncology team. She is a member of the Siopen Executive Committee, chair of the Siopen Translational Steering Committee, and chair of the Siopen Biology Committee. She is also, are you still co-chair of INRG? In addition to her care for children and adolescents with cancer, she is involved in clinical and translational research programs. Her work focuses on the study of molecular mechanisms involved in cancer progression and clonal evolution in neuroblastoma and other pediatric cancers based on biomarker studies using liquid biopsies and on single-cell analysis. Future aims are to integrate biomarkers into integrative treatment approaches while working towards a better understanding of the underlying genetic and epigenetic modifications involved in the oncogenesis and tumor progression. She is also involved in personal and precision medicine approaches at a national and international level. Dr. Gudrun.
Thank you very much. It's a huge pleasure to be here and to speak here in this important conference. And thank you very much to the organizers for inviting me. And when we think about treatment for neuroblastoma patients, I really think the most important thing is thinking about getting the right treatment to the right patients. And I think for this, as we learn more, it becomes more and more evident that we really need to work together across borders worldwide, because we need to come up with really more information so that we can share data in a meaningful way and think about all the different aspects of which treatment for which patient. And I would like to go really through some information with regards to how we approach this in the European setting, but highlight really also the connections with what is ongoing here with COG and other cooperative groups. So what is Siopen? Siopen is our European neuroblastoma research network, which is currently chaired by Lucas Moreno and with the co-chairs Juliet Gray and Cormac Owens. And in fact, this was set up over 20 years ago, initially really with the aim of setting up clinical trials. And as well as I will explain, really we have made this work also in the context of research initiatives and translational research so that we can bring data both from the clinical trials and from the research institutions together. So when we think about treatment of neuroblastoma, we know first of all that it is really important to think about this in terms of risk for a given patient at the time of diagnosis. And in Siopen, as in many other cooperative groups, we are aware of the importance of these pre-treatment risk groups for neuroblastoma patients that take into account really the basic clinical features, age, stage, as well as pathology and genetic alterations. And then we have some kind of idea of an algorithm that is currently being more and more refined, and I know in the upcoming days we will hear more about these factors so that we can really stratify treatment to the best of our knowledge for a given patient. And this is why within the big INRG setup there has been this overall concept of pre-treatment risk groups. However, even though we have this as an overall scheme where we use common language, we know that there are still some differences, and I wanted to just highlight some of these in our European. Why is this moving so fast now? Right, I can't talk that fast. I need to go back. In our European setting, we use some definitions slightly different from what is being done in the COG trials that you will hear about later. And some of these differences concern that I have no idea why the slides jump faster than I speak, but some of the differences concern the age cutoff. For us, patients with metastatic disease over 12 months are treated as high-risk disease, and also for patients below 12 months, we have some distinct features that we take into account when thinking about whether a patient needs treatment as for low risk as opposed to intermediate risk. All of this has led to and integrated into the major clinical trials that we have run within the Siopen landscape. Siopen, again, meaning trials that are run between 15 or even 20 European countries. And the major overall trials that I will speak about concern the HRNBL1 trial, a trial that ran for over 20 years for high-risk neuroblastoma, and which is now being pursued in the high-risk 2 trial, as well as different trials for low and intermediate risk neuroblastoma. So within these frontline treatment strategies for neuroblastoma and high-risk disease, in Siopen, as in many other contexts, we firmly believe that treatment for high-risk neuroblastoma really consists of different treatment phases, with an induction treatment, local treatment with surgery and radiotherapy, and also the important place of consolidation that in our context usually is concerning high-dose chemotherapy and the importance of maintenance. And for all these different treatment phases, we also believe that the further integration of novel prognostic and predictive biomarkers will help to refine treatment, and probably for all these different steps in the future enable us to identify patients who might need more of a given treatment block or less, or where we might fine-tune these approaches, moving away from a one-size-fits-all to a more adaptive treatment designs. The high-risk 1 trial that was led by Ruth Ladenstein recruited over 3,500 patients with high-risk disease over 20 years, with a median follow-up now around 10 years. We will hear more about this and different sub-analyses performed within this trial in the coming meeting. What we have learned from this really important trial is first the confirmation of the major prognostic factors: age, stage, also the number of metastatic compartments, meaning the number of metastatic sites involved at the time of diagnosis, as important factors that will impact outcome medium and long term. And also with regards to the treatment itself, for the induction phase, a randomized trial had been conducted comparing our European rapid Kojak induction with another treatment induction, and we could show that both achieve the same results in terms of response at end of induction. However, the European rapid Kojak was less toxic, so this is why this is currently our standard for the induction. I do think that it is hugely important to think about how to align different induction regimens across the Atlantic Ocean and worldwide, and work is ongoing to think about how that can be achieved. With regards to the high-dose chemotherapy and consolidation, in a randomized manner, we compared the busulfan-melphalan to other high-dose chemotherapy regimens, and here the busulfan-melphalan achieved better results, also with regards to toxicity. And in our setting, with the overall treatment strategy, this is what has been retained for the European context now. And of course, as expected for the maintenance, the anti-GD2, in our hands, it is dinutuximab beta, which is not exactly the same antibody as the one used in COG, but the principle is the same. Of course, adding that to the maintenance as opposed to retinoic acid on its own clearly leads to improved outcome. And all this has been integrated into the overall concept for the high-risk 2 study that is currently ongoing, led by Claudia Pasqualini, where additional questions are being asked with regards to add-on in case of insufficient response after the first cycles of induction, also the comparison of 1 versus 2 consolidation steps, as well as important questions with regards to the intensity of the radiotherapy. This trial is ongoing, and I need to stand on my toes so I can see the bottom of my slide. With regards to inclusion, now more than 550 patients have been included, and we plan an amendment to be able to introduce ALK inhibitor treatment for patients whose tumors harbor ALK alterations in the near future. What about patients with low and intermediate risk disease? Here I want to just speak very briefly about the European trials that have been led over the last 10 years by Adela Cagnette in our LINES protocols, which propose treatment stratified according to age, also the presence or not of symptoms, and then what we call a genomic profile to enable us to fine-tune treatment into different treatment groups depending on what we call a favorable versus unfavorable genomic profile outside MECAN amplification, of course. And this leads to an overall concept of more or less treatment that is fine-tuned, and we can show, and we will hear more about that in the coming days, that we can probably avoid treatment or really just give very minimal treatment for children with low-risk disease who probably just need very few cycles of chemotherapy. And within this LINES trial, we have clearly showed the feasibility of using such biological markers, the genomic profile, across our nearly 20 biology laboratories in 20 different countries. And I'm highlighting the importance of doing these so that we have an overall excellent survival that is maintained while having minimal treatment. What about treatment strategies for neuroblastoma at relapse? Here also Siopen has run a number of trials, and I would like to mention the important Beacon trials, which were led by Lucas Moreno and Juliette Gray. And within this, different chemotherapy regimens with different chemotherapy backbones were analyzed in terms of efficacy, first combining this with Avastin, bevacizumab, leading to an overall response rate of 30%, and then in a second step, the chemotherapy backbone with dinutuximab beta, and here a response rate of 35%. And these treatments were proposed both for children with either relapsed or refractory neuroblastoma. And what could be learned is that both the combinations with bevacizumab and dinutuximab beta led to activity. And however, just temozolomide on its own, and no surprise, that is clearly not sufficient for a child in relapse with a high-risk neuroblastoma. And further work is ongoing to look at this more in detail and to look at the biology of the tumors of these children. And this is integrated into the current Beacon 2 design, which is being led by Lucas and Juliette, with the idea of having a multi-arm, multi-stage trial within which we further explore the use of dinutuximab beta versus the bevacizumab with a chemotherapy backbone, and then new agents can be brought into this overall trial design to be taken forward if we think this is relevant. So in our overall strategy for a child with high-risk neuroblastoma and treatment failure, we will propose this Beacon strategy. And then if that is not sufficient and the child is still in a new relapse, or we do not receive, there are not insufficient results, then we need additional strategies. And within our overall European network, we then have an overall portfolio of early clinical trials, which are either molecularly driven, requiring the identification of biomarkers, or large-scale, independent of the biological background of the tumor. And we know also that further thought needs to be put into further consolidation if after high-risk relapse we can achieve disease control. And for this, a number of discussions are ongoing so that we can move further consolidation strategies forward for children for whom we can achieve disease control in these difficult situations. And so within this context, we know really that there's a huge importance of integrating biomarkers further. And this is being achieved within what we call precision medicine, where we think that integrating large-scale molecular profiling is of importance so that we can address patients towards the relevant early clinical trials, depending on the molecular profile. And I will speak about that a bit more in detail in just a few minutes. Overall, we have realized that there's a huge importance of being able to integrate data overall from the different clinical trials, which, as I mentioned, are run and sponsored in different European countries with different databases and maybe biological samples collected in different contexts. And so also inspired by an initiative that has been existing in COG for over 20 years, I think we have come up with the important concept of what we call the Siopen bioportal, within which we set up a network where we register patient data and the information on the biosamples that are collected so that we can share them in a meaningful way, independent of the trial that a patient is enrolled in. What is maybe important to know is that in Europe we have really strict data privacy rules, and sharing data outside clinical trials is also an issue, but always an issue. But within the Siopen bioportal network, we have come up with a context via a consortium agreement linking all the different countries, all the different trial sites, independent of the trials, so that we can collect registry epidemiological data and also the biological data via such an agreement, and that enables downstream data sharing, which I think is crucially important. And I'll just go through the slides very quickly to say that in such a context, then when we collect data, we might be collecting data on genetic information such as ALK mutations in the high-risk 2 trial, but we might also be collecting more vast data with regards to the molecular information itself, and we might need to make that available for further research independent of the clinical trials that the patient has been enrolled on. And our Siopen bioportal enables us to do so with the relevant consents and respecting all the European data protection rules, which can be complex, and very glad that this is now ongoing. And some graphs to show just the overview. I don't need to go into the detail here. And the important aspect here is that the Siopen bioportal also feeds into the global INRG database that you will also hear about more in detail, and which collects data from patients with neuroblastoma throughout the world. The scheme that I had showed up front with the different risk classification is actually based on the INRG data that had been collected for an initial 8,800 patients under the leadership of Andy Pearson and Sue Cohn, and is now rapidly expanding. And with our European setup now, we will be able to contribute to this in a meaningful manner, both for clinical data, epidemiological data, and genetic data. And when we speak about genetic data, I didn't look at my timer, so I don't know how much time I have left. Do I have 10 more? Yeah, I have 10 more minutes? Okay. I spoke about the fact that I think it's really important that we think about the overall genetic profile of tumors of children treated with neuroblastoma at the relapse setting, and probably also up front. And for this, we need to consider what we call biomarkers more in detail. I put in a few slides to think about what we mean by biomarkers, meaning essentially anything that can be measured in blood, in body fluids, tissues, and that might be associated with normal or abnormal biological processes or a condition or a disease. And when we speak about diagnostic biomarkers, we mean anything that can be measured that really confirms a pathological diagnosis. Prognostic biomarkers mean something that we can measure and that for an overall patient population will identify risk groups, as we had mentioned up front. Whereas a predictive biomarker means that we can use this information for a given patient in order to predict how this given patient will respond respond to a given treatment. And it is important to make this distinction because depending on what we call biomarkers, we can use them in different contexts for overall treatment design, as opposed to, of course, the decision for a given patient in a given situation. Prognostic biomarkers in neuroblastoma really have been known for decades now, and of course the classical example here is that the MIC-N that we know is associated with poorer outcome and has been integrated in a clinical setting for decades. But there are some, and I wanted to mention the paper that clearly shows MIC-N amplification outcome in low risk and intermediate risk neuroblastoma. But then there is some additional information with regards to that. MIC-N amplification itself is in fact not of prognostic importance when we look at high risk neuroblastoma, because here the survival curves, they overlap, and even the MIC-N amplified ones, the blue curve, in fact, you can see the patients with MIC-N amplification in the high-risk protocol probably might relapse a bit earlier, but then on the long term, their outcome is not poorer. And then we have this important observation also that MIC-N amplification might be heterogeneous, meaning it is seen in some cells but not others, and we don't really know yet how to integrate that overall. And the example of predictive biomarkers in neuroblastoma, the typical example of ALK. So we know that if we identify an ALK genetic mutation, we think that might be predictive of response to ALK inhibitors. But here also recent work has indicated that probably we need to be able to refine these predictive biomarkers. We're still not 100% sure which patients would benefit the most from ALK inhibitor treatment, and probably here also collaborative work across the different collaborative groups will lead to novel knowledge to best identify patients where this treatment will be of an advantage. And when we think about all of this, we need to know that there are ever-evolving techniques. They evolve from one year to the next, and we need to be careful when we integrate new techniques into the clinical workflow that we use for decision-making for our patients. So we have learned in neuroblastoma that overall there are few genetic mutations that are recurrent. Most of them concern ALK, some the RAS-MAP kinase pathway, chromatin remodeling, and what we call the telomere maintenance. But we have also learned, and from a lot of work done in different labs, including mine, that these genetic alterations are not stable and they change over time. And so if we want to use biomarkers as prognostic or predictive biomarkers, we are actually in a situation where ideally we would need to measure something on repeatedly, because what we can see at the time of relapse is not the same as a tumor at the time of diagnosis. And we have shown that at the time of relapse, we see many more mutations. We see ALK alterations in probably 20% of patients, whereas at the time of diagnosis, we find them in 10% only. And just going through this quickly, this is why we think that within what we call precision medicine programs, really detailed profiling of neuroblastoma samples at the time of relapse is hugely important. In the European setting, several such programs have run, which analyzed tumor tissue at the time of relapse of high-risk disease with really state-of-the-art sequencing approaches. These are called whole exome or whole genome sequencing. So we look at the whole genome or all the genes, and we combine this with a full expression profiling with techniques such as RNA-seq. And what we have learned from this, combining data from different national programs, is in fact a really refined information with regards to the mutational landscape. And we see that in relapsed neuroblastoma, approximately 35 of them have MIC-N amplification. That's nothing new. The ALK mutations can be seen around 20%, as I mentioned before. We really see a frequency of mutations that target specific pathways. We call these the RAS/MAP kinase pathways, and they might suggest other targeted treatment that might be important in that setting. And overall, molecules, proteins that we call receptor tyrosine kinase, that are proteins that are on the cell surface and that can be targeted with small molecules, are found in 30% or over 30% of neuroblastoma at the time of relapse. But how can we integrate the fact that, in fact, these profiles change between diagnosis and relapse? We all know of the difficulty of getting a new tumor biopsy at the time of relapse, and this is why the information that we can derive from liquid biopsies is so important. We and others have shown, without going into the detail on the slides, that we can use a simple blood sample to analyze the DNA that is coming from the tumor cells to get a molecular profile of relapsed neuroblastoma. And in a number of recent publications, it has been shown that we can use this information from the cell-free DNA to identify genetic alterations at different time points. And of course, a blood sample is a lot easier to obtain than a tumor biopsy. This is why we think that this really needs to be integrated with a really overall analyses on liquid biopsies in the relapse setting and in a repeat manner, which is why we are integrating this in our overall workflow for molecular analyses and diagnosis of neuroblastoma in the Siopen setting. And this is why we really think that in case of relapse, ideally a new tumor tissue should be analyzed. But if this is difficult to obtain, then just remembering that we can analyze the liquid biopsies with the same techniques, looking at ALK mutational status or other mutations that might be relevant in the relapse setting is of importance. And because we can use liquid biopsies in two instances, and we can use this both for looking at the specific genetic alterations as a predictive biomarker for a given patient, but we also want to know whether this is useful for the follow-up of patients. And my colleagues Lieve Tidgat and Sabine Taschner are leading a European-wide randomized trial within which we are exploring whether the use of liquid biopsies as a means to measure disease burden and look for relapse early will have an impact on overall survival. And within this Mona Lisa trial, we are conducting a randomized trial which for the first time integrates these liquid biopsies, not only for a means to have a predictive information with regards to the genetic alterations, but also to look prospectively at whether this information detecting relapse earlier will have an impact on the outcome. And this whole trial is also linked to patient and parent-reported outcome and quality of life to evaluate all this in a prospective setting. 3 remaining slides to share with you how I think these molecular information needs to be integrated in the overall landscape throughout Europe. In Europe, we have a number of these precision medicine programs that we are leading in the different countries. It's called Inform in Germany, either in the Netherlands, SMPEDS in the UK. That is not important. What is important is that we do really extensive sequencing of relapsed tumors using techniques such as whole exome, whole genome sequencing, expression profiling, and methylation. And we think that this information can be used in a meaningful manner to match a patient who is in treatment failure after the standard treatment arms to choose relevant early clinical trials, which are proposed in different setups and multi-arm platform trials, or if no trial is available and the patient receives off-label treatment, at least collecting the data in observational platforms. And we have set up such a platform under the leadership of Pablo Berlanga. It's called Sasha, and all information for off-label treatment is collected in that setting. The next 2 slides are complex to highlight just that in these overall platform trials, we do not propose a direct match, one genetic alteration, one mutation, one treatment, but it is more the idea of enrichment, an enrichment strategy, and under the leadership of my colleague Birgit Georger, this overall proof of concept design of eSMART and other trial arms aims at grouping patients in different treatment arms based on the overall profile that can be identified in patient tumors in case of relapse. And we think that collecting this information in this manner enables also to go back and look at the data and analyze the data from patients who have responded versus those who have not. In some of the eSMART arms, for instance, those proposing treatments that are of relevance, we think, when different pathways are impacted, we could see, for instance, that a treatment that we call a V inhibitor that was proposed if there was alterations in a gene called TP53, in fact led to some responses in neuroblastoma. But going back to look at the data, the biomarker that was of relevance was not the TP53, the reason why the patient was selected for that treatment, but in fact more alterations in pathways that we call DNA repair. All this to say that we think that within these different precision medicine programs, we really establish the feasibility of the high throughput sequencing in a clinical context. And we believe that we can identify these targetable alterations in over 60% of children with cancer in treatment failure. However, only a small percentage leads to drugs that are already ready for clinical routine use. And in a number of settings, we need to think about how we can use that data, and the enrollment in either trials or observational studies that enables us to go back and get the information across different trials is crucially important. And with that, I would like to highlight the work that we're doing in our Siopen translational research community, really linking the clinical trials, the biological sample collections, and the output from these different initiatives so that we can, in the future, know which treatment is right for which patient in a given situation, and really come to what we would call really adaptive treatment for a given situation at a given time. And with that, I would like to thank all the many funding organizations that support our work across Europe and worldwide, and the people in my lab for the few slides that I had included from my lab work, and also the Siopen Bioportal. And I hope I wasn't too long, and thank you very much.
Does anyone have any questions? We have the microphone here and over there, so if you'd like to get up and ask a question, please do.
Thank you. My question has to do with the liquid biopsies. If those liquid biopsies on relapses or subsequent multiple relapses continue to show no mutation, what does that make you think? How do you interpret something
You mean
like that?
if a liquid biopsy is performed but there's no mutation at all?
Yeah, and that, repetitively,
Yes.
Maybe
So yes. So there are different layers to that question, because of course, first of all, it might be, we know that there are a number of neuroblastoma, probably around 10 or 20%, that don't shed any cell-free DNA, and we don't really know why yet. But I think it's important to analyze that. Then if no mutations are found, the second question to ask is what technique was actually used, and we need to compare what we call the copy number profile, because most neuroblastoma have alterations in this genomic copy number versus the mutations. And sometimes just the information liquid biopsy test is maybe not all the information we would need to answer that question, but where you look, was ALK analyzed, or a smaller panel, or a wider panel, or all the genes? And so if nothing is found, it is important to know with what how this was analyzed, in fact. Then I think it's important to know that today, even though we think this is important, we don't always know how to use this information for a given patient. And sometimes we see things that we call subclonal, so it means it's just in a few tumor cells, but not all of them. And I couldn't go into this in detail, but we need to think more in detail about how events that just concern a few tumor cells can be integrated in the overall treatment strategy. That was a long response for a short question.
Anyone else? Okay.
Are you using the microbiome portion of your research strictly for predictive purposes? Or are you considering maybe fecal transplant? And the other question is have you found a correlation with any of the microbes that are linked to positive outcomes as a relative to negative outcomes?
Yeah, so I don't have any updated data on that. I know 2 research teams that are looking into that and studying the microbiome in the wider sense, and also looking at this in different mouse models to show the impact on immunological findings and treatment resistance. So I think it's an important question, but I think we don't have the answer to that yet.
Thank you.
Anyone else? Oh, go ahead.
I'm from Portugal. I because we are under Siopen. I have this question, which is more political than really has to do with treatment. But we see all these programs that are going on, and I was wondering if there is there any way that we can. I guess my problem is that there's lack of effort on some of the leaders or some of the people who are on Siopen in Portugal to actually bring in some of those programs, some of the clinical trials that are happening around Europe, and even the liquid biopsies, for example. I remember I came to one of these conferences and I asked Dr. Mose, regarding the possibility of us doing it somewhere else. And then that prompted us to our doctor to speak to her, and we arranged that in Portugal. So it can definitely be done there.
Yeah.
But it's just that it was me that made the effort to for that to happen.
Yes.
So I know that Europe speaks at different languages and different voices and different speeds, but I was wondering if there's any way of integrating all of that so that we can be part of the...
Yeah, so I agree that we need to align and try to integrate all countries in the European network, also some of the Eastern European countries where there's still a bit of discrepancy on what are the tests that are being proposed in case of relapse. And I think we're working on a minimum standard, and liquid biopsy, blood sample can be taken easily. It can easily be sent to another country, and within the Siopen biology network we're currently working on recommendations so that we can at least get that done, because again there's some low hanging fruit that we should look for any child in relapsed neuroblastoma to not miss possibilities of treatment.
Okay, thank you.
One more? Go ahead.
I just had a clarification question on your liquid biopsy section. Did you say that 81% of the liquid biopsy results line up with like a physical biopsy? There was an 81% metric on that slide, and I was trying to confirm exactly what you were saying there.
Yeah, so we had a study where we had compared the results of the liquid biopsy with a tumor result, and indeed we found that these align, but then that means that 20% don't. And so you see a lot of findings that are not in the tumor, but that we see in the cell-free DNA that's circulating in the blood. And so actually, I think ideally, in case of relapse, we should always aim for a new tumor biopsy if we can, and if we can't get it, we can't, and do the liquid biopsy in parallel for all patients. And I think that should be a new standard. Well, it already is.
Thank you.
Thank you.